Thank you for joining us today. First, I'd like to thank all of our panelists for taking the time out of your busy schedules to come join us. I'd also like to thank all of the members of UHA Cleveland who worked really hard to make this roundtable possible. UHA Cleveland is an undergraduate student organization at Case Western Reserve University that aims to address various aspects of healthcare access and health literacy through initiatives and collaboration amongst like-minded organizations. My name is Miles. I'll be one of the moderators today representing UHA Cleveland.
My name is Rachna, and I'll be the other moderator representing UHA Cleveland. According to the Health Policy Institute of Ohio, heart disease was the third leading cause of death for working age Ohioans, accounting for 5,654 deaths in 2022. Today's roundtable panel aims to educate and promote conversations regarding cardiovascular disease and its effect on our surrounding community. Joining us today to talk about this issue are three specialists who come from extensive backgrounds in healthcare, education, and activism. We'd like to begin with a quick description of our panelists' backgrounds.
All right, first off on the left here we have Dr. Erica Chappell. Dr. Chappell is the Associate Professor of Population and Quantitative Health Sciences and has served as the Associate Director of Community Outreach and Engagement at the Case Comprehensive Cancer Center since 2020. She also directs the Prevention Research Center for Healthy Neighborhoods at Case. Dr. Chappell is trained as a behavioral epidemiologist and has led a community partnered research program for over 15 years. Dr. Chappell's research has focused on tobacco control, dietary interventions, and cancer screening behaviors among marginalized populations, as well as examining implementation of individual systems and policy interventions to increase reach, broaden impact, and improve health.
In the middle, Dr. Sherry Boland is the Alfred F. Connor Senior Health Services and Population Health Research Professor, Professor of Medicine and Population and Quantitative Health Sciences at Case, Founding Director of the Population Health and Equity Research Institute at the Metro Health System, and a general internal medicine physician. Dr. Boland also serves as the director of two separate cardiovascular community initiatives, Cardio and the Cardiovascular Disease Programs for Better Health Partnership. Nationally, she recently served on the Department of Health and Human Services National Clinical Care Commission, charged with developing policy recommendations for persons living with diabetes, and serves on the Centers of Disease Control and Prevention National Hypertension Control Roundtable. Her career has focused on the implementation of evidence-based strategies and innovative programs within primary care clinics to improve cardiovascular health outcomes and advance health equity.
Last but not least, on the right here we have Ms. Sonia Besmar. Ms. Besmar served as a development director for the American Heart Association school site program for 10 years before moving into a community CPR manager role, where she spent 5 years working with affiliate partners to provide bystander CPR training across the Midwest region. In 2019, she accepted the new role of RQI Business Manager, working across the country to engage, educate, and help deliver a new standard of resuscitation with a focus on quality improvement in hospitals and health systems. As of 2021, Ms. Besmar was promoted to the Vice President of Community Impact to serve as a consultant across the greater Cleveland region on community and population health strategies with a specialized focus on systematic changes to drive health improvement across under-resourced communities.
Our discussion today will focus on cardiovascular disease and more specifically on the following subtopics in order. First, the impacts of socioeconomic determinants of health. Second, current research. Third, disease prevention. And then fourth, current or potential solutions. Although there's a lot to be said, we would like for each segment to be limited to about 20 minutes. Additionally, we're recording this panel in hopes of distributing it to the wider community. And lastly, before we begin, I'd like to offer the audience the opportunity to join in whenever they have something to add or to pose further questions. Because cardiovascular disease is a community problem, we want to promote conversations between everyone in this room while being respectful of each other's opinions. Without further delay, let's begin.
All right, before we delve into our discussion on cardiovascular disease and its impact on Ohio communities, I'd like to start by asking each of you to share a little bit about your personal journey into cardiovascular disease, research advocacy, and our initiatives. So could you tell each of us about how you became involved in your respective field and how it pertains to addressing cardiovascular disease? And additionally, if you have any personal anecdotes or research findings that highlight the effect of cardiovascular disease on individuals in Ohio, we would love to hear them. So anyone who'd like to begin, go ahead.
Sure. Okay. Well, firstly, I have just, one, being an African-American woman raised in this country, in this state, I have been, I guess disproportionately, my family has been disproportionately affected by heart disease, just as relates to the access to healthcare and information. And so while I didn't originally come to the American Heart Association because of that, as I worked here over the years, I became very passionate, making sure that I was able to provide individuals that access to information and resources that they wouldn't necessarily have. Specifically, I'm talking about our underserved communities, our Black and brown communities. So that for me personally is a passion. I have personally experienced, sometimes I think in the past, maybe some, how would you say, maybe some treatment that maybe wouldn't be necessarily the same as someone who is not a Black or brown person. And so that has driven me to really, I think, learn how to be an advocate for myself, but also to help people to learn how to advocate and ask the right questions, and trust in their own feelings about their health care, because that is important. And I think while we live in an amazing country with amazing education and access, or not access, but access to great medical care, there's individuals that I think maybe aren't fully aware of everything that they're that's available for them to access. So for me, that's just my personal experience. As far as American Heart Association, our main goal is to build a life full of longer, healthier lives, free of cardiovascular disease. And so all of the work that we do always ends back to heart disease, whether it's how we look at the way you exercise or eat or anything like that. Everything kind of goes back to that. So that's just personally for me, my focus. I think these two women could probably give a little bit more as far as like on the medical side or the statistical side, a little bit further than I, so I'll pass it to whomever.
Yeah, thank you for that question. It's always nice to reflect on what brought you to where you are in the work that you do. I think I really started to think about how can we better care for individuals when I was a resident, and I was treating mainly Hispanic and low-income Black populations at my clinic, and really felt like we could do better within primary care for patients and all of the challenges that they address, and how do we better partner to do that, as well as how do we improve just high-quality care within primary care. So that was a big focus, and a lot of my patients had diabetes, so I was very interested in diabetes, and for people with diabetes, high blood pressure is a big risk factor for them to pass away from, actually, as opposed to blood sugar. Everybody thinks blood sugar for diabetes, which also is important to control. So I really got focused on hypertension and blood sugar control part of residency, in addition to having personal experiences also within family, etc. So I really focused on trying to enhance the work I was doing in primary care through research. So I got a master's in public health to do that. And as the public health school motto was saving lives millions at a time, which is more of a public health motto, and as opposed to, which I also really appreciate, seeing patients one at a time also is important on the medical model. But so both I think are really important to do together and can be very helpful. So that's really led me into the work I do here. And then more recently, Metro Health sort of combined several research centers into the Population Health and Equity Research Institute, where we have 17 faculty that are working around health equity broadly, as well as health improvements. And so I really enjoyed working to try and build more faculty and more staff that are focused on this effort so we can have greater impact. And a lot of community engagement and alignment with payers and other stakeholders to try and improve health.
Thank you. Yes, thank you for the questions to reflect, and thank you for the opportunity to be here today. Following similar themes, I lived the first 10 years of my life in the Deep South, and saw a lot of things that were very impactful in shaping sort of my outlook on life, and early exposure to racism and disparities and inequity, and just the realization sort of how things became unfair and how those unfairnesses really affected people's lives long term. I also grew up in a family where everyone was a smoker, and it was perpetual, and everyone was unhealthy. And at that point, the first 10 years of your life, you're not necessarily putting all those things together, at least not at that time. But it was clear, and it was also clear that everyone was saying, this is a disgusting habit, don't ever do this. We're never gonna stop, but you don't need to start. Fast forward to college, was trying to figure out what I wanted to do, and sort of had this conundrum of, do I go into medicine or do I go into public health? I didn't necessarily have those words just yet, but I started in my undergrad on a research project that was a health behavior change project, and started to see really the power of prevention. And where there was more information now about what are the things that we can do to be more proactive in taking care of our health, to prevent disease. What are those risk factors? Which led me ultimately into a doctoral program in epidemiology. And at the time that I was coming out, there was a big focus on tobacco control and recognizing the role that tobacco has really in exacerbating so many diseases, not just cardiovascular disease. And the realization that it's really not just about personal responsibility, that there are multiple levels of influence that contribute to that behavior. So that's really inspired me in recognizing sort of, again, the unfairness, the inequity, the manipulation of people into this bad behavior because of money as a bottom line. And when we put money ahead of people, to me that's just not okay. And so we continue to have these opportunities to improve public health that are challenged with the economy or other things we see at the local level, state level, certainly at the federal level. And I sort of take my spaces when we generate the data that shows the impact that we can have, not just on individuals, but on millions. That should really speak for itself, and can keep pushing that agenda to have impact across all populations in our country.
All right, moving into our first topic, individuals from disadvantaged socioeconomic backgrounds often face higher risks of developing cardiovascular diseases due to various interconnected factors, including but not limited to access to healthcare, unhealthy living environments, inadequate education, and financial strain. These disparities underscore the profound impact of socioeconomic inequities on health outcomes, highlighting the need for targeted interventions to address underlying systemic issues. By exploring the causes of these disparities, we hope to shed light on the specific challenges faced by the Cleveland and Ohio community so that we may develop strategies for addressing them effectively. How do socioeconomic factors intersect with cardiovascular health outcomes, and what are the root causes of these disparities? What factors do you all think contribute to the high rates of cardiovascular disease in Ohio, or Cleveland specifically?
I'll start. I'm gonna give an easier start because I want to let you all both give some deeper answers. But I want to just, as an epidemiologist, what I like to say is I really appreciate this question because it can be very easy to just, say, well, poverty is associated with this outcome, so it must be something about poverty, and that's it, right? To sort of write it off. So I think that it's wonderful to hear the question being, what's the deeper interpretation? What's the context of that? That is just an indicator, but it's an indicator of so many other complexities of lived experience. It's not just about that, but your income is the indicator, right? It's the indicator of likely where you're able to live, the things that you are able to access, the decisions and the challenges that you have to work through every day of your life. That then lead to health or proactive preventive things being a lot more challenging for you for many different reasons, not because you want them to be. And we tend to say, well, let's change that. Let's just change, if they made more money, like it's so easy, right? Like it's such an easy thing. That's an indicator. It is not a thing that is actually what makes the difference. It's everything that that sort of represents. But as an epidemiologist, I think it's really important to always say, go past whatever that little statistic is and get what's underneath it, because these things are not often as simple as we'd like them to be. You know, if you read research papers, sometimes we sort of say this is this. We know that these associations exist, and now to really get to solutions, which is where we need to be, we need to understand why and engage more people in those conversations and have creative solutions that build on assets, and also recognize the challenges that are created by the systems that we have to all work through or move through, and put the responsibility and the onus on those systems really to change as opposed to the individuals.
That's a great intro to answer that question. And this, you know, I'll try and keep it relatively brief when I say after that, because this could take a whole hour discussion just in and of itself. I think, you know, in Cleveland and other areas, you know, redlining created some structures in place in our society that made people of color have a harder chance to have opportunity, and that led to a lot of the challenges in terms of poverty that we do see. However, it's, as you were just mentioning, sort of beyond that. So we, you know, redlining is not, you know, actively happening currently that we can see, meaning banks aren't necessarily only funding certain areas and certain people. That is obvious because that's not legal to do, but there are certainly implicit biases that people have, as well as explicit biases that people have that still influence how people may receive care, the opportunities that they may receive. And so I think those are real and still occurring in present day, and are things that we still need to fight against in the work that we do. And so I think, you know, being cognizant of that, trying to recognize when those things are happening, trying to stop or set up processes in place within the structures and systems that people work in, I think is good. Certainly having any influence in other areas where you can, I think is important. And then it is very complex because people have many different you know, challenges related to low income and food insecurity, and all of those cluster together. And how do we think about a lot in the healthcare system about tailor care and address those particular barriers as we give care. But then I think we need to think more broadly about just, again, the structures and systems and how can we influence those in conjunction with others.
Well, they've said it all. I would just, I agree wholeheartedly with both Dr. Bowen and Dr. Travel. I would add that one important thing to go along with redlining is that just a few years ago, the council stated that racism was a public health crisis in the city of Cleveland. And that really is so true, because everything stems from that. It goes back to Dr. Trappel said, you know, in Dr. Bowen redline, where you can live. So depending on where you live in Cleveland, that's access to a certain type of education. If you don't have money to pay for private education, then you're going to maybe have to put your child in a public situation, and that's not saying that the public system isn't good, but the public school system is overwhelmed and overburdened. So those are all the things. I think also a big issue is just in the work that I do in the community, culturally, there are a lot of different things that, in different ways that Black and Brown people may feel about education, about trust towards the medical community, trust towards, you know, bigger institutions. And so I think we have to go like way back, and really education is really important. I think the key is education, and I don't mean like you have to go to school, but I mean like actually, again, I'm always going to be like really big on having access to resources and education. You don't have to have a degree, but you do have to have access to that and know more. And I think it makes a difference coming from people that look like you, because there is that trust. And that's hard sometimes because just in the nonprofit industry, you don't see a lot of people of color in the nonprofit. And it's not because they can't do it, they probably don't know that it's a great industry to work in and they could benefit from it. I also think an important thing, to going back to the cardiovascular disease, is it's important to get people of color involved in studies because those also help to, I think, create how medicine is looked at, as we move forward. And so all of that, along with what they just said, I think is really important as how we'll move forward, in hopefully fighting cardiovascular disease. So.
Thank you so much for all your insights. I think we really like to hear more, but we're going to have to move on to our next topic. So, historically, a lack of diversity in biomedical research has led to misdiagnoses, ineffective treatment plans, and exacerbation of health inequities, among many other consequences I haven't listed. But in the case of cardiovascular disease, different populations exhibit non-identical symptoms and respond differently to different treatments, right? So how can we increase diversity within cardiovascular community-based research and translation so that healthcare professionals can most effectively provide personalized care to each and every patient?
Yeah, it's a great question. And here in Cleveland, we have, and actually now Northern Ohio, we have the Clinical and Translational Science Collaborative, which is funded by the National Institutes for Health, and we just got funded on that for another 7 years. And one of the main goals of that is to figure out mechanisms and infrastructure to better support getting people enrolled in research so that we know better how to treat different populations and have diverse populations in research. So that is a big aim. And there's different ways that people are trying to go about this. One thing we're trying to do here is develop a really strong community and stakeholder network so that we can have that trust and relationships built, so when people do come with different research questions that we can connect them and make sure it's a priority to the community and have their voice and what they think is really important to address as well. And then really work together as we think about opportunities to improve the health of communities. So we have a new community advisory board. We're working on developing a community network, so that's in process over the next the next 7 years, but we're really starting that work now. And then I know there's also been some of the church-based networks and others that have been already connected with for the work, and trying to leverage, really we have a lot of those connections, but they're all siloed in little pieces and parts through different people. And so how do we bring that together so it's more of a resource for everyone? So those are just some things off the top of my head. I think the other piece that you mentioned was sort of workforce development. So one was, incorporating diverse populations into research, and the second one was sort of building a workforce that's more diverse. And that's really important as well. There's another part of the Clinical and Translational Science Collaborative is a workforce development module. I think that's geared more toward bringing people into research careers as opposed to necessarily becoming other healthcare professionals. But I think the medical school also has been working on developing pathways for diverse groups to attend medical school and other healthcare professional study programs within the nursing school and within the medical school and some of the social work programs as well. So I think that's, I don't know as much about those initiatives as probably maybe Erica knows a little bit more about that, but I think that is on the radar, at least for the Dean of the Medical School, where I know that they've developed some specific programs to enhance ability for folks to come into those programs, since that is so important.
That was great, and I'm excited to follow you because you were talking, it reminded me a couple of things. I'm going to bring in my epidemiology slant. Why is a standard average temperature known to be 98.6? Where did we come up with that? Anybody know? Why is the standard blood pressure 120/80? I'll tell you, if my temperature is 98.6, I'm not feeling well. I'm one of those who runs cold. So in epidemiology, we do sort of population level statistics, right? We say on average for everybody. Does that mean it's the same for you? Maybe not, right? So then that means we have to pull from some population. We love cohort studies. It's one of the ways that we've learned the most about health over the period of time, right? You enroll people and you follow them longitudinally to sort of see what naturally happens. What kind of people were originally enrolled in some of those early cohort trials, right? Who did we follow? A lot of white men. A lot of white men. Don't see a lot of those in the room at the moment, right? So, but we made assumptions early on that clearly if this works for white men, it must be true of everyone else. I think one of the most classic differences is, symptoms of a heart attack are not the same for everyone, particularly for women. And how long were women told, oh, you're just having some pain. Oh, it's not something to worry about. The problem was we didn't have the systematically collected cohort data, and or if we did, no one was looking at it, to inform that there may be differences in how this is done. And this is why it is so important, and we have a renewed focus on making sure that we have diversity in our samples for research, because when we don't, we run the risk of making assumptions on the limited populations that are actually included in our research. So how does this play out? I gave you this example. Let me give you another. We have what's called the U.S. Preventive Services Task Force. This task force comes together with certain committees, and their charge is to make recommendations that are actually uptaken by the Centers for Medicaid and Medicare, right, to determine reimbursement for insurance, right? These are best practices in care. They can only make recommendations based on the evidence that's available. So if your evidence and your data doesn't start until 55, they can't say anything about what's happening for those under 55. And when we get the soundbite, we're like, well, 55 to 70, this must be the age that's really important for X, Y, and Z. Not realizing, and right, we might implicitly say, well, maybe everybody underneath that is safe. When really that's not the case. There's just inadequate information, inadequate research to fully form a recommendation, because we just haven't done that. We haven't collected that data. We don't say that as explicitly as we need to, that there have been inequities in the design of research, in the delivery of federal research dollars, that have created a disparity in the data that we have available to adequately inform, right, best practices in care and treatment and prevention. And that's not just true in cardiovascular and heart health, but in all diseases. So this is why this renewed focus is recognizing we just don't have the data to answer those questions as much as we can. And if we're doing things going forward, we need to ensure that we're being inclusive so that we don't miss things and inadvertently put other populations at risk because we're not paying attention to the full spectrum of the lived experience.
And I would just add, from the American Heart Association perspective, we have a local board where we have representation from every health system and even some federally qualified health centers as well that we talk to about different things. We use, as an organization, we are a science-based organization, and use evidence-based strategies, and so that all the work that we'll ever do is around that. And so we share that information. We have conversations at a higher level to try to address some of these questions that you've asked. Additionally, we have a STEM program for young girls. It's called STEM Goes Red, and so we love that because we are hopefully starting them early to be excited about the science, technology, engineering, mathematics field. We have donors and sponsors that will provide scholarship opportunities for these girls if they choose to go into one of those fields. So we're kind of trying at that level to engage. When we talk about diversity, we don't see a lot of that in some of these fields, and so we're trying to incorporate that in some of the work we do. And then there's also, we do things around social impact fund. We're a large organization, so we have the ability to make those connections with other large organizations and hopefully be able to help provide funding to make some of these changes. So we have social impact funds, we have business accelerators, we have things like that that are geared specifically towards diverse candidates and individuals. So that's what the Heart Association tries to do.
I'm gonna
Yeah.
I'm going to toot your horn for a second because I'm actually a host from a national program, the American Heart Association's Summer Undergraduate Research Experience Program. I hosted someone last year who was just phenomenal, and I'm hoping to have somebody else again. So there's a recognition, right, from lots of organizations nationally to create opportunities to diversify at an early stage so that we continue to support the diversification at later stages of the systems as well.
Thank you for that insight. I definitely agree that starting young and incorporating that diversity early is critical. Given the complex interplay between socioeconomic factors, access to healthcare, and individual behaviors in shaping cardiovascular health outcomes, it's evident that effective policy interventions are crucial for addressing the root causes of cardiovascular disease disparities. So with that in mind, I have a couple of questions for you all. First, how can policymakers, healthcare providers, and community stakeholders effectively collaborate to develop and implement policy interventions that promote cardiovascular health equity? Second, what specific policy interventions do you recommend? And then third, do you three have any specific experiences working in the policy field that you can maybe shed some light on?
Sorry.
Touchy subject.
We're laughing because we just had a very significant state policy issue that Sonia and I are still recovering from.
Yes.
But maybe Sherry, I'll let you go first.
Talk about success.
Yeah.
Yeah, well, it's a good question. I think I've done some policy work in different spaces. We had, and I'll just give two examples. One was this National Clinical Care Commission, where I was very excited because we were required, this was a commission that was required by Congress to form to evaluate gaps in federal programs and policies for people with diabetes and make recommendations that Congress was required to act on within 90 days. So I was sort of excited about it. It was a volunteer, piece, and it was 3 years long, and we made a lot of recommendations. I think the challenge I found at the federal level is that even though they were required to act on it, I don't know that they ever really made any major changes from that. That was a little frustrating at the national level. It doesn't mean that we still aren't advocating through different organizations like the American Diabetes Association or others to make changes, and hopefully we'll start to see some things from the work that we did, but it wasn't quite as magical as I thought it might be when I thought they had to act on it in 90 days. So that was a little disappointing at the national level, although again, I think that there was a lot of momentum and a lot of people worked on that, so I think there will be some things that will come of it. At the state level, we've had a little more success because we've been funded by Ohio Department of Medicaid to work on improving both high blood pressure and diabetes across the state. And so one of the things that we were able to do as part of our diabetes work was get all the Medicaid managed care plans to remove their prior authorization for continuous glucose monitoring, so now a lot more patients could actually get that. And then we also got them to cover the diabetes self-management education and support programs, so those were not covered by Medicaid at the time, although Medicare covered them. So that just allowed access to a very important program for patients. And then we also had the diabetes prevention program that we leveraged to try and get covered, which Medicaid now covers. So that's been a very successful collaboration, mainly because the Ohio Department of Medicaid is actually supporting the work and then really wants the Medicaid managed care plans to work together to standardize their activities and really improve care. So that's something that's been really fantastic, and I look forward to seeing we are continued to be funded by them, and I'm hoping that we can continue to push forward policy level changes around different activities. So that's sort of a positive policy level experience. And I think those are my one frustration, there's probably others, but those are the two that are immediately coming to mind.
I'm going to talk about some things related to tobacco. And one's a positive, and then the other's just reality. But one thing I will start off by saying is that all policy is health policy. Every policy has some implication on health for some person, regardless of what it is, right? Every policy has health implications in its health policy. So, I've been working in tobacco for over 20 years. One of the first areas of work that I started working on is in these cigarillo products, little cigars. We realized that they weren't regulated. We started to ask why. And luckily, this was the question and conversation that was happening at the national level. And in 2009, President Obama was the president at the time, and there was a recognition that we needed a more formal structure to regulate all tobacco products, not just those that had happened to be regulated. And so it established within the Food and Drug Administration the Center for Tobacco Products, which then had the regulatory authority to establish policy, right, to regulate tobacco. What this did then is allowed us to say we don't have sufficient evidence to make rules about certain things, right? We don't have the data. We need to identify the gaps and we need to fund those. And so there was effectively a federal mandate to say, let's start to do that. It pushed a lot of money into what's now known as tobacco regulatory science. It allowed us to develop the science around cigar products, around vapes, around other emerging products, around menthol, things that had not been currently regulated so that we could gather data to shape and inform those things. That's been very exciting, and what's been exciting to follow was that in April of 2022, 2 new rules were proposed based on all the research that had been done and funded through these regulatory science grants. One was to ban menthol from cigarettes. Very excited, we've been waiting for that really since 2009, even before. And then the second was to ban flavors in cigar products. We had ample evidence to suggest that flavor was appealing to children. And this was really an avenue to hook children into starting early and continuing. You know, what was even more exciting for all of us watching this is that we knew President Biden was the president who was ultimately going to get to sign off on these. And for those of you who don't know, he's had a long-standing commitment to cancer because of his son who died from brain cancer, and when he was vice president, launched what's called the Cancer Moonshot. So certainly, a president who has a commitment to cancer, it would be a no-brainer, right? Let's get those through. Well, it took a long time to get out of the FDA and to actually get over to President Biden. They got over to him late last fall. So you might say, well, wow, Dr. Travel, why are those still sitting there? Why do you think those are still sitting there? And I don't know, I know you're all very busy and very studious, so you probably don't look for tobacco information in the news like I do. But what's happening this year that's very notable?
An election.
There's an election. What does an election have to do with protecting the health of millions of people in the United States of America? Shouldn't have to do anything, but that's me talking as an epidemiologist, right? I'm not the president of the United States. I'm not the Democratic National Committee. I'm also not other groups who perhaps have some support from the tobacco industry who is very bothered by this policy, saying, well, you might lose the black vote because it might be racist to ban menthol.
That is the crazy.
For many of us, we think it's crazy, but there are people who are saying, and if one person says it, and then it gets picked up on social media, and then it's picked up on the news, it feels like it must be popular sentiment. So these 2 bills, these 2 pieces of legislation, policy, that could affect millions of people's lives, have substantial impact on the proportion of people who experiment with tobacco and become dependent upon tobacco and experience tobacco-related diseases like cardiovascular disease are not protected because there is chatter about how this will affect the election. I'm not making any stretches here. This is the national discussion, and it's horrifying because you realize, and I don't feel like I can go back to the state conversation, but what you realize is where it should be very logical that these are things that are for the public's health, right? This is how we all agree that we have a government to do to protect people's lives. This seems like it should be an easy decision, and yet here it sits, right, with ample evidence, ample research to show the negative impacts, the disproportionate and inequitable impacts of tobacco industry practice, and yet it sits with the president who has been the most committed to cancer since cancer funding began 50 or 60 years ago. It's not for the faint of heart.
I think Dr. Trapple's a little bit passionate, but I'm not sure about that. As she mentioned, we do work on a lot of things together, policies, most recently tobacco. In my work, one of the things that I try to do is when we work in our different communities, we try to make sure that we're making a sustainable health impact. And so for us, what that looks like is making sure that when we go into a community and we provide education or resources or funding, that once we leave, the expectation is that they can continue to do this, make whatever change that was made and do the work needed once we've left. That's sustainable for them. And so locally, some of the things that I may work on are around, let's just say, we work with health systems on quality programs around how, on hypertension. You may not know, just the way you sit can affect how your blood pressure is read. So things like that, again, I go back to science-based evidence, or science research, evidence-based strategies. So we work with healthcare systems on really just trying to do what we have determined through our science is the best practices so that we can hopefully inform and change the outcomes of individuals through these practices. We do things like policies. We work with organizations like policies to something as simple as a cardiac emergency response plan. Do you know what to do if I were to go in, well, we got Dr. Bowen here, but do you know what to do if I were to go into sudden cardiac arrest right now? Is there an AED? So things like that. You know, we try to work at the little level, but we also work at the state level on tobacco, and then we work nationally on food as medicine, looking at food as a way to combat you know, your health through nutrition, access to nutrition. So there's all kinds of things that we do. But I would say with the tobacco thing, one of the things, and it's funny, it's not just at the state level. For example, one of the things I've been extremely passionate about is trying to, because as Dr. Trappel said, we're seeing that kids are becoming hooked on really vaping and the flavors, they make it easy. And so we've been trying to work with school districts to change their policy on weight because these kids are getting hooked. So it's not just about them doing it, they're actually hooked. How do we help them, you know, not smoke anymore? And so schools are, you know, have policies and how they will react towards a student if they're caught vaping. And it might be something as simple as, well, you're suspended. But we need to look a little deeper. There's a problem here. If a child is vaping in school, there's a problem. It means that there's a strong addiction and there's a problem that they can't even wait to get home. So we need to look at that. So those are some of the things that locally we try to work with our different community organizations, health systems, businesses, and things like that. But we also do tobacco. And unfortunately, it's not for the faint of heart. just what Dr. Travel says, not for the faint of heart, so.
Can I just add one more thing, because I know your question also said, and I didn't touch on this, like going forward, what policies are important, and just a couple, and I think there's actually a lot, because a lot of things affect health, but I would just say a couple areas that I think would be really important. One is looking at taxes or taxation or other policies to address the use of sugar-sweetened beverages, to reduce that as we think about the contribution of that toward weight gain and weight gain to lots of health problems. The second is salt and how much salt is added to food, both through processed foods that we get and food industry, as well as restaurant food. So I think that's, again, sort of policy change at the sodium salt level can have a huge impact on blood pressure control and cardiovascular health. And then the others are things that we're working on, you know, trying to get the use of validated home blood pressure machines so that you have accurate readings when we work with payers to make sure those are covered and not just any machine that's the least expensive that may not be that great. So there's some things on that side. And then the last thing I think that's really important in healthcare right now is how do we cover addressing social drivers of health, and I call them drivers instead of determinants, but you know, how, if we're spending a lot of time addressing those things that contribute to health, like food insecurity, financial childcare, housing, and the list can go on, then how, if we're going to do that in healthcare, how do we reimburse for that for community organizations that are helping cover those services, as well as community health workers? So that's a big piece that we're trying to work on. We have some coverage for Medicaid enrollees around addressing social drivers of health by paying community health workers, but it's very piecemeal and an area that needs a lot of attention going forward.
I just want to add one more quick thing. I think also community activism is really important. A lot of the work that we do cannot move forward if we don't have people in the community using their voices and their power of going back to the voting. And that has been a big struggle, is how do we get people engaged to care and to speak up and to show up to help, support the work that we're trying to get done. I think that is key if we're going to move anything forward.
Yeah, thank you for the specifics you guys mentioned there at the end. The next question I have is going to be pretty similar actually, but I'll just lead into it. So many organizations have made efforts to provide resources for underserved communities. For example, the Valley Health System, in partnership with the Cleveland Clinic, offers free heart risk assessments for men and women starting at age 20. Ms. Besmar, we'd appreciate it if you could start us off, since you have involvement with the American Heart Association and CPR training. Given your experiences, what are some key components of effective preventative care programs for cardiovascular disease, and what issues do you see in current initiatives that could be improved?
So I would say, thank you for that question. I would say the biggest thing is, and I think I mentioned this earlier, it's all connected. And so the work that we do, what we just talked about, we focus on food, because what you're putting in your body makes a difference on how your heart's going to work. We focus on exercise. Most recently, we've been focusing a lot on mental health and well-being. That is huge. You don't have the mental capacity to get out of bed and do the things you need to do to take care of yourself. You're already, at a setback. So some of the things that I'm working on locally, again, with hospital systems, we are looking at ways that we do things to combat heart disease. Like Dr. Boland mentioned, it's really important to have accurate blood pressure readings, because if they're not accurate, then that could really kind of skew what you're looking at. And so we work with these systems to put policies in place where we're asking them to say, hey, just like Dr. Boland mentioned, it's important that you use the right validated devices so that we're getting the best readings. And so we work with organizations to do things like that, as far as, again, having a cardiac emergency response plan in place. But in addition to that, making sure that people are trained in how to do bystander CPR. I think we all saw last year, or at least aware of, Damar Hamlin going into sudden cardiac arrest during the football game. That kind of, that's always been our organization, that's always been what we focused on, but we've had a lot of people start really paying attention to it, because we're also starting to see a lot of young athletes that are going into sudden cardiac arrest. And so my job is to just get the training, the information out to the community as much as possible. How to recognize the signs of sudden cardiac arrest. How to recognize the signs of, if you're having a heart attack, man versus woman, because those things are important. How about if you're having a stroke? There are so many women that have strokes and they just brushed it off because they thought they were just stressed from work. So there's all kinds of things like that. We all have our months. This month is Heart Month, so we focus a lot on education, awareness, especially with women's heart health. And we try to engage our local news stations to talk about it and share out that information. But for me, again, the work really focuses on creating that policy or system change within the organization. That's how we are able to kind of move to the next step. Because if you don't have a good policy in place, then you're just basically, spinning your wheels, I think.
Yeah, I think those are great examples. I think we, on the health system side, we probably focused a lot on a lot of the things we already discussed, which was, the importance of prevention is also around the social drivers of health, since those contribute to cardiovascular health overall. And so really thinking about how we can address those and the work that we do is going to be really important. And then I think, of course, the lifestyle and blood pressure measurement and salt and diet and those kinds of things all, and weight, and how do we help help decrease weight if it's an issue.
And
But
I think we should add too that we all do assessments too, community assessments. I just want to say, I think that's important too, because we look at what our community needs through assessments and then make decisions based on that too. So I know you know that, but
yeah, no, it's good
Yeah.
to point out that we
Yeah.
have community health needs assessments that relate to those social drivers of health, and then we're working now with a lot of community partners to try and provide those wraparound services to patients, and that's a big effort, really, of all the health systems in the region, plus a number of our community partners. I think we have 300 community partners that are part of trying to address those services, but some have greater and lesser capacity to do that, and so how do we better support the community organizations to really provide those services? I think will be a big push, and then hopefully in the next 5 or 10 years we can think about ways to support that work better.
We've probably spent the better part of the past 3 or more decades learning about interventions or strategies that can help with managing chronic conditions or to prevent chronic conditions. And in the research space, right, we get our 5-year grant, we design our intervention, we evaluate our intervention, we're like, okay, we're done, we figured it out. Somebody else's job to make it happen, right? And there's this sort of realization that we have all these evidence-based approaches, but what have we really done to make sure that they get out beyond the research or wherever they've started? And so there's been more of a focus, probably over the past decade, on implementation and dissemination. So how do we take these strategies and really move them out? Organizations like American Heart can be really great at saying, let's do this on a larger scale. Let's make sure we're pushing out these strategies so that more people know how to use AEDs and use these life-saving interventions. Healthcare is doing a lot of work on quality improvement, right, and figuring out how to do that, and we're working more with our community partners. One unanticipated ally, I don't know if that's the right word, has actually been workplaces. And it's not necessarily because they're warm and fuzzy, right, and care so much about their employees, but because workplaces offer health care benefits, right, and they pay in to be able to provide employees with those benefits. And the healthier workforce that they have, right, the less they're paying for that insurance, and the less they're losing in sick days, right? So this is a bottom line of money thing. But this is where some of us have had to sort of learn, how do we use that bottom line of money to motivate folks who aren't necessarily prioritizing health like some of us to do these things in a different way? And so, and to use more of a carrot as opposed to a stick, right? A reward as opposed to a penalty. And so it wasn't uncommon in the last 10 years for there to be discussions about, well, people who smoke have to pay more. Well, now it's people who don't smoke get a benefit, right? So that orientation sort of changes. Here at CASE, I work at CASE, if we go and get a biometric screening every year, we get a little benefit in our paycheck. And what that does is it just makes sure that, if there is something, an elevated A1C or a high blood pressure reading, that we're then encouraged to go follow that up because we're taking care of our health, right? What's moved beyond that, and I was surprised over this last year, I don't know if you all have seen this with your health insurance, but there are now companies that will actively reach out, because I'm on Medical Mutual, I'm a Medical Mutual, insured client. Medical Mutual has partnered with other companies that are sending information like, do you need physical therapy? We can offer you online physical therapy so you don't have to go to your primary care. I know we could probably have a separate conversation about how effective these things are. But right, the idea is that, so there are these separate programs. There's also, just within the university, they've partnered with offering stress relief programs, dietary programs, Weight Watchers programs, right? And so the university says we've made time and space to invest in this because we want you to be able to be healthier. We recognize the challenges maybe of time and space, and we're saying we're promoting that. So as much as health policy, right, health is in all policy, health can be found in all of our organizations and places and institutions that we interact with in different ways, and how those support, again, healthier, making healthy choices easy. That's one of the things the CDC used to say, how do we make the healthy choice the easy choice? And we can think about that in all different ways. And I think that's where we'll start to see more innovation, is how do we get, it still remains to be seen who engages in those and how effective they are, but what are the innovations and how we get things to people? Because not everyone, since COVID and probably even before, our healthcare systems are stretched in that capacity. Not everyone is going to be able to get into a doctor's office the day that they want to for whatever issue. So how do we create some other options that are supportive, that still provide a quality experience, and work within the constraints that we currently have?
Well, awesome. Those insights are definitely helpful and I think can inform some future policy. In the spirit of contributing to an ideal future where cardiovascular disease is no longer a major health issue in Ohio, we'd like to move forward in finding specific approaches to both improve healthcare access and general awareness. While this is a very complicated issue, we hope to discuss ways and gain an understanding for both us and the audience as to what steps can be taken to find solutions to the issue. So with that, I have a couple of questions. Do you see a future where the cardiovascular disease rates in Ohio are significantly reduced? And if so, how long do you expect this to take? And what can small-scale organizations like UHA Cleveland do to help?
Ohio is one of the top 5 highest rates of smoking in the country. The average is 12%. Ohio is 20%. The city of Cleveland is 35% of people, adults currently smoking. To me, when we drive down smoking, we see all diseases come down. To me, the most effective and most powerful thing we could do would be to support tobacco control activities and tobacco control policies that A, prevent kids from starting, and B, help people who want to quit be successful in quitting. There's an entire book on how we do that. And it requires a lot of partnership, a lot of collaboration, and commitment to doing that. Right now, because our hands are a bit tied with local policy options here in the state of Ohio, one thing that any of you could do is join up in statewide efforts to promote adoption of tobacco policies at the state level and support and educate around that and get people registered to vote and encourage them and educate them on these sorts of things. The other thing, at least locally, is identifying opportunities to, again, prevent initiation or promote cessation, and there are lots of folks that I think your organization could connect with to learn more about specifically how you could support that. That's going to be my party line. Just we can get those rates down, we'll see movement.
Sure. I'll quickly say, I think also providing help to individuals to just acknowledge that there's an issue. And that might be, I know talking about our community assessments, one of the things that is an issue, a large issue in this community, is transportation. People don't take care of themselves because they don't have transportation to get to a grocery store, or you might not even live in an area that has a grocery store, or get to the doctor. So we're trying to think about things out of the box where we can work with like local health clinics to provide maybe some funding or access to get transportation in order to get patients there. Also, like maybe thinking about some people that you may not usually talk to with questions. Like we work with some fairly qualified health centers that are utilizing their pharmacist for a lot more than just giving out medication, but like kind of being like a precursor, having some conversations so that they can kind of work with the doctors to follow up. And then one of the big things that the American Heart Association is really looking in, and I know our organization, we use Teledoc. Because of the pandemic, I think a lot of like things, and it's not perfect, but it's something. And I think like, and I'll just use my husband for example. He does not want to go to the doctor. But if I'm like, well, just, use Teledoc, you don't even have to leave the house. he's more willing to do that, and then he actually, like, they've helped. Again, they're not gonna perform an operation on you, but there's like some simple things, they do help, and I think when I look at like some of the counties I work in, like Ashtabula is considered rural, they don't have a lot of access to stuff too, so if we can do things like that, again, like I said, there's still some kinks to work out, it's not perfect, but it's an option, and I think that that's helping, because then it gives people at least the ability to maybe talk or try to get help where they maybe otherwise wouldn't.
I think those were a challenging set of questions.
I just said tobacco.
Yeah.
Yeah, I mean, I've thought about this a lot because, you know, cardiovascular health is a combination of the interplay of so many different things that are really important and are different person to person. So if you're, you know, a physician and you're seeing someone in the office, what you might do with that individual to reduce their risk versus what you might do on a population level is going to be very different. And then if you're thinking about population level, you want to address, you know, so many of those different interplays that are really, you know, highly prevalent in a lot of people. Like, we know mental health is an issue. We know that mental health contributes to worse cardiovascular health. We know that smoking obviously is there. Hypertension and having an elevated blood pressure is a very strong risk factor. Not cholesterol in and of itself, but we know that cholesterol medication, which we think works in different ways than just lowering cholesterol, but actually prevents heart attacks and strokes, and those are at highest risk. So I think there's a lot, and then the social drivers of health, which really contribute to health. So there's just a complex interplay of very highly prevalent conditions and risk factors that really need to be attacked together to reduce, you know, cardiovascular health in the state of Ohio. And Ohio is actually unfortunately in the top quartile of states for the worst, you know, heart attacks and stroke events compared to other states in the United States. So we have a lot of work to do. And I think, you know, especially if we think about health equity and eliminating disparities in cardiovascular health, again, thinking about those social drivers and the interplay there is going to be really important, as well as the targeting of certain products to certain populations and trying to address those risks. So I think it's complex. I don't think there's a one answer. I think it actually needs to leverage lots of you know, sort of alignment. And so some of our work to create a statewide cardiovascular health collaborative and our regional health collaborative, most recently with the CDC grant, is to try and align different organizations and partners who are doing work in this space so that we can have a greater impact together, because no one person can address all of those things. So really having that alignment, trying to work together in a complex way to really impact these problems, I think is going to be super important going forward. And I hope that we will see a change because we have to be optimistic and do what we can. But I do think it's going to take complexity and working together to really make it happen.
And I just wanted to add one other thing, because you brought up a good point. A lot of things we also have to consider is that some of these risk factors are non-modifiable risk factors. And so, for example, we just looked at the state of Cleveland. Cleveland is 40% African American. So already you're starting, you know what I mean? So like, again, it's so complex. You have to look, you can't just make it one whole picture, because you have to look at each individual area and see how they're made of. Women have certain, you know, non-modifiable risk factors. So yeah, it's all very complex, and I just wanted to add that, because I do think that is a big part of why it's so complex.
Yeah, I think that's a good point, that whenever we write grants too on this, we're like, we're going to focus on the modifiable things, like the things we might be able to attack around social drivers and try and address, like tobacco use, blood pressure. You know, these are things that are modifiable. We can't change somebody's sex easily, and there are ways to do that, but it might be a little, might be not what people are looking for as the answer there.
I think too what you're also hearing is it's at the higher levels of influence, right? So of course I'm going to be the diehard on policy, but of course it's not a silver bullet, right? And I do I'm just going to toot your horn, right? I think that the work that the Quality Improvement Collaborative work that Dr. Boland leads is so important, because it's changing systems, right? and it's sustainable. So when those things get changed and when providers are integrating those things into their practice, that has multiplied impact, right? And it's on all the, I'm just thinking about all the different things, right? All the different topics that come up. So that best practice is getting out broadly, right? That all these things are what's gonna add up to impact. And being able to have resources like this and people like Dr. Boland who thinks about this work and people like Ms. Besmar who are advocating for policy, it takes all of us are just like, okay, it might only be like a 0.5% change, but that's a lot of people, right? And that's important. It gets us closer and closer as we go.
Yeah, thank you for addressing that tough question. So before we conclude our roundtable panel, I just want to ask the audience if anyone has any sorts of questions they want to ask our panelists. And if you guys have any last things you want to add, I think this would be a great time to do it. Yeah, so anyone in the audience? All right, it doesn't look like it, so I'll see if you guys have any last things you want to add. If not, we'll finish up.
Oh, there's one.
Oh, yeah, go ahead.
So I have a question though. When you come to policy making, in order to help with issues of cardiovascular diseases, how do you deal with a system that does not bend to the concept of rationality? Because there's a number of concepts that you just mentioned that very much strikes me in a kind of a wrong way. In which we talk about if we would have healthcare for all of the workers, then obviously the obvious answer is that it will create a more productive workforce and less things you have to spend on healthcare for people, and that will mean more profit. But the problem, the reality in many places is that profit is of secondary importance for the people who own the business, and it's more about control than anything. They would do very much irrational things if it means they can maintain that control. We can see that very clearly with the COVID pandemic, in which they desperately want everyone to go back to working in person, even if it means it will increase much higher chance of infection and more of a detrimental to their workforce. And that's on top of the fact that when it comes to legislative measures, we have people who are absolutely hell-bent on making sure that everyone is inaccessible to healthcare at all. And this is not because of some different concern. It is literally just because they don't think it is a human right. And the third point on top of this has just been existing in the background of all of this is that this is a profiteering healthcare system in which people don't, one of the reasons people are so afraid of just getting to medical field on top of all the racism, all of the mistreatment, it is just that that bill could be the end of their career, their house ownership, their mortgage, their family. And in which case, how would you rectify that if it's such a deep problem in which all of our basic necessities, all of our basic need is just so tied intrinsic to very unethical practices that has been refused to change?
Yeah, that's a great series of comments and reflections and questions. It's one is around beliefs and how do you get beliefs, and then one is sort of the system around access to care and the financials that are related to that. So I think from a belief perspective, it can be challenging to work on that. I think some of the things that we've tried to do around beliefs are, one, ask a bunch of open-ended questions about to better understand what somebody's beliefs and thoughts are. And often there's alignment in a way you might not have thought of. You might come in with an argument that you think is rational with your set of beliefs, and that maybe that's the general belief of a lot of people, but Individual beliefs are quite varied, and so understanding what people's beliefs and cultures and values are can be really helpful in getting them to move in a direction that you might want them to move in. And maybe you use a rationale that would speak to that belief over the one that you might be thinking of. So, and I'm not saying that's perfect, but we've often, I think, going in to try and understand what their concepts and beliefs are and how they feel about health or a particular thing has been helpful to us when we've tried to engage partners. And I see you have your hand up, so you can respond to that again. But I just wanted to go ahead. You can.
I'm just like curious because like when we talk about belief, this is also operating on another assumption that all we have to do is explaining ourselves, and that the moment people come to an understanding of each other, they would be able to move in unison. My problem with that idea is that these are not people, this is my comment, the general comment I have in general, is that these people are not, this is not misunderstanding. They understand it very well. As a matter of fact, they have studies, they have people who work for them who are very good at understanding people. It is just that they deliberately want to use that understanding to do very bad things. And they have institutional power.
Okay, thank you for that clarification. Yeah, I think that's right. There's a group of people where, I guess I was trying to speak to like what's rational for us isn't always the same as somebody else, and that there's sometimes opportunities in leveraging somebody else's belief system to move something. But I think what you're saying is, they have a way they want to go forward, and then they've rationalized how they're going to go forward, and they're not really open to hearing anything else. And that can be challenging. Some of the things that can be helpful is being able to show benefit, but I think in your case you're saying, well, we can show benefit, but they don't really care about that.
They haven't done that in decades, if not centuries.
Yeah, I think that's very challenging, and other people can comment more. I mean, I think you have to work with the folks that are willing to work with you, and sometimes there's pressures that can be leveraged to those people from other people at similar levels to them, and sometimes you can't. So there's sometimes those leadership level areas where they can be leaned on by others, but sometimes that's hard to do, and you have to do the work, around them, and then hope that you can eventually, move that needle too. The second part of your question was, I'm forgetting, was access to care. So I would just say, I think we should be, the politics of having a universal health insurance coverage for everyone did not go through, obviously, when Obama put that through. I think that is the answer for a lot of things, including the rising cost of healthcare, which goes to a lot of the administrative work of different health insurers. So I do think from a policy level, moving to health insurance for all, if we ever can get momentum around that, would address the issue of, would address some of the issues related to finance. The second is, I agree completely with that comment around, the finances. Metro Health in particular has, financial aid, and they can work with people around that, but different health systems feel maybe more or less inclined to deal with financial aid and supporting people through that. So I think there are systems in place, but only at certain places, and it can still be very problematic.
I just want to clarify that comment, because when I was talking about like accessibility to healthcare, I don't mean like insurance or like copay or anything like that. I mean like actually lowering the price rather than tying this accessibility to insurance, because there's two problems with that. Is that usually it's tied to employment, and the second part is that it usually does not cover a lot of things, and it's created a model for very predatory practices. I personally know many people who has been very much messed up over this. And one trend that I see on social media that is as clear as day is that they move to other countries around the world, and they have been describing it, the medical procedure that they have been receiving, to be basically world-class compared to what they live in the US, and that's literally the reason why they will never come back here again. And I think like that is basically an indication of just how bad things are right now.
Yeah, like the issue of being underinsured, or you might be insured, but you're underinsured. It's not
And-
covering the huge debt that you have. It's not just the access to, and that, I think that again, that is, some institutions will work more with patients around that because it's part of the mission of the hospital system. But I think in general, you're right. There's a lot of, you see this in the news a lot, right? That people are trying to get cancer treatment and they're going bankrupt. I know there's policy that has been out there. Yeah, the cost of insulin, that was one of the many recommendations we made to Congress. So I agree with you. Thinking about the policy level changes we can do around that are going to be important, but are very challenging.
I was just gonna, share my experience sort of as a researcher and thinking about policy. I sort of said I never wanted to do anything that had history or politics, and I realize now in my job that understanding history informs policy, which is also influenced by politics. And so, as I have learned from my wonderful advocacy colleagues at the American Heart Association, there's always this sense of understanding what are people's motivations. And sometimes it will be, like you said, they want to have control, they want to have these things. And you have to put those front and center to come up with a strategy on how to pitch, right, your goal to those folks, and if there is a way to do that, and if not, how do you find another pathway, or go 2 degrees out. Well, if I can do this thing, but then just this thing, it might shift this person. I think it's been described as like this is the making the sausage, right? It's not always a nice, warm and fuzzy thing. It's for me personally, it feels kind of gross. Other people really get excited about the idea of strategy and doing this sort of work. And I'm so glad they exist because they are a wonderful counterpart, right? I bring all the data. Data doesn't move a lot of people, right? So just as Ms. Besmar said, having community voice, whatever that stakeholder is, whoever your constituents are, making sure they're present. When we brought some of our data to Cleveland City Council, they're like, our residents aren't asking for this. And then our small business community is saying X, Y, Z. So if we're going to get involved in that work, and it sounds like you're very familiar, and I appreciate the complexity of your question, we have to understand that there are going to be different perspectives, different motivations, and we need to get ahead of those and understand them so that we can position ourselves better. I don't have anything to add beyond what Dr. Boland has already said about the dire needs of our healthcare system, and I appreciate exactly what you're saying. I think those of us who see this are like, what can we do? And elections and voting are nice to say, but it doesn't move fast, right? It doesn't help the people that we know are struggling with these issues right now.
I would just agree with what they said. I mean, one of the things that the American Heart Association, we always say we are science-based, and people can try to argue with science, but it's science, and so that's usually always our motto. And again, it's just how you present it to the person. I mean, let's call it as is. We live in a capitalistic society, country. It is unfortunately about making money, and so it's how do you get their attention so that they feel like when they walk away they're winning something, but we've won something as well. And I think it's just how you set the conversation up. But again, it's at the end of the day, it's individuals who are workers, and keep this society running. Those are the ones that have the power. It's just how do you organize them to understand that and then do that. And so I think that's a big issue as well.
Yeah, very interesting you mentioned that point. So this is something just from personal experience, but I know a number of people who has administrative power who has been very much fundamentally against unionization in an effort to get better working condition and healthcare. So yeah, I really need to hear your opinion on that because I feel like this is where a lot of people just don't want these people who supposedly has power to change things to have collective bargaining power, and that is one of the biggest roadblocks in getting people just better working condition or better life at all.
Okay, I appreciate that we've gotten some discussion. Just for the sake of time, I think we're going to wrap things up here, and we can try to ask individual questions after the panel. So on behalf of UHA Cleveland, I'd like to thank all of our panelists and audience members for their time and insights on the important and prominent issues discussed today. We would also like to offer our sincere appreciation for all the extensive work and effort of our three speakers that they've put into scientific research, diminishing health disparities, and advancing social justice over the course of your guys' careers. The discussions that were held in this room today are only some of the small steps towards alleviating the prevalence of cardiovascular disease. And if you're interested in checking out more about what UHA Cleveland does, please check out our website. We have some URLs posted around the rooms. And we'd also appreciate feedback on this event, so if you could scan the QR code and maybe fill out the Google form, that'd be much appreciated. Feel free to stick around and talk with any of us and grab some food. Thank you, everyone.
Thank you.